Now I'm going to invite Tit Albreht to come to the floor, and he's going to speak to us about the next steps on the Beating Cancer Plan, what's happening next in Europe. And Tit has a very long experience. In Slovenia, he's the member of the Health Council at the Ministry of Health and also the head of the Centre for Healthcare at the National Institute of Public Health, and lots of experience at European level. So you're just the right person to us to answer this question. How can we create cooperation programs that support all countries in achieving the gold standards in Europe? We heard Slovakia was a slow starter, and there are other countries that I think are even further behind. How can we get everyone up to that gold standard that we're aiming for at European level?
Thank you, Tamsin. Good afternoon to everyone. Thank you for the invitation. I think actually the adoption of the Europe's Beating Cancer Plan was an important step. I will quote a previous intervention, I would say, on the side of the European Commission, which actually triggered a lot of action in the member states, and that was the call to adopt national cancer control plans or cancer control strategies in member states. And most member states, a vast majority, responded positively on that initiative, even though just a few years before, many countries were quite resistant of having the Commission interfere in their national health policies. You could say that. We even remember that from our first presidency where this had been the case. So now we have a different momentum. And now we are not at the declarative stage, as some declarational stage, as some colleagues have already mentioned. We need implementation. And I think that this is now the key word. So we know how to prepare a decent document, we know how to prepare a decent strategy, but now we have to become operational. We know, speaking of colorectal cancer and other cancers that we can screen for, we know that the sheer recommendation, like the one from 2003, does not result in automatic pickup and introduction and implementation of screening programs. I think that the boost of the pandemic given on data has two sides, like always. The positive side is that people are much more interested in data than probably ever before. The general public, professionals, different interest groups, and so on. On the other hand, with COVID, there were two negative sides, I would say. One thing is that the public continues being, of course, has been flooded with a lot of numbers. Sometimes without proper explanations. We saw amazing mistakes being done with more complicated indices like incidence rates and so on. And secondly, we cannot fool ourselves that in cancer we can have instant data like in infectious diseases. We know we can transpose data, but we cannot know about someone dying of cancer this morning, this very moment, like we do of COVID. This doesn't say that we should not invest in speeding up, but I would say that this stresses the importance of registries. And one of the speakers mentioned the reliability of the data. Expanding data on socioeconomic status is important. Why do I mention that? Literacy. I think, Tamsin, this is something that is close to your heart. Literacy has been challenged enormously. And in addressing and approaching screening programs, we need to be extremely cautious that we do not leave some people behind. Some of my colleagues, also from Britain, are very weary of screening programs, actually, because they fear that we might lose people. Like our Dutch colleague said, with the impressive rates they have, there is 30% of the people who are left behind somehow. They shouldn't feel like that, but that's the problem. So now I think that the mobilization of the policies is necessary in practical terms. I think there are already some indications from the Commission. For example, the HPV initiative. It's another story, of course, it's not directly related to our today's discussion, but nevertheless. And I think that I'm very happy, I have to say, about the developments in Slovakia over the last few years. They were lagging behind for a long time. Many of our colleagues there were frustrated, but now there seems to be a big momentum going on. And I was really listening very carefully to the lady speaking from Slovakia. So it means that this top-down is not always so bad as some people think. It actually pushes us to organize ourselves better. And I think that this is actually the core of what we can approach. And we have to link ourselves to the structures that are becoming important, like the Cancer Knowledge Center in ISPRA, for example, as part of the European Commission, and the European Network of Cancer Registries.
Thank you, Tit, for again giving some perspective that some countries like Slovakia have made big strides from where they were, but again making the point that this is the knowledge that's already acquis. We know how to write strategies, we know even how to write action plans. What we haven't necessarily delivered on is implementing that and turning that into practice. And again, I like the fact that data is a double-edged sword, as you mentioned. It's great to have all of this real-time data, but we can't expect the same kind of data for all conditions. And I remember even the huge arguments that there were at the beginning of the pandemic, arguing about how you were collecting a death rate. And Belgium was having this very inclusive, which was within 28 days. And so it made it look like Belgium's death rates were higher than other countries. And you had politicians having to defend the death rates in their country by saying we calculate them differently. So as you say, and everyone talking about, is it the R rate we should care about or the infection rate? Lots of different complicated epidemiological terms that had to be simplified for public communication, but then created quite a lot of confusion. So thank you for that overview. Let me now bring in Ciaran Nicholl from the Joint Research Centre, which is part of the European Commission. And you are the head of the health unit in Health and Society unit there. And we'd like you to give us again a little bit of a perspective on where the Commission's implementation roadmap is, which was just launched before Christmas on the Beating Cancer Plan, and specifically zoning in on this issue of the screening. You know, what do we need to do next? How do we make sure that these screening recommendations from the Council actually get implemented, and who's tracking it? What are the tools we've got to actually make sure it's being done at high quality in different countries? Ciaran.
Good afternoon, well, at least in Central European time, to you, Tamsin, and excellent moderating, by the way. I want to first of all thank Zorana and the Digestive Cancers Europe for the invitation, and I want to compliment the speakers so far. It is great to have access to such knowledge and such expertise, and it's great to see that we're all uniting together to really make a change and let Colorectal Cancer Month March be a real success. So on behalf of my colleagues in Santé and also DG Research and in the GRC, I'd just like to pass a first message regarding flagship 4 of the Europe's Beating Cancer Plan. So in terms of implementation and impact, and we heard those words a few times, and that's exactly the key. If we don't have implementation, we won't have impact. Basically, the Europe's Beating Cancer Plan is now putting forward a new EU-supported cancer screening scheme to help member states ensure that 90% of those who qualify for screening in the European Union will get it for colorectal cancer, also for lung and cervical cancers, and the deadline 2025. Not too far away. So basically that means funding will be available to member states to help to achieve these targets. And this is exactly where we have to go, especially for a cancer like colorectal cancer. The focus for that initiative will be on 3 main areas. Number 1, on access, number 2, quality, and number 3, on diagnostics. So basically, there are a lot of things happening. I'm very happy to announce that the Commission is united like never before when it comes to tackling cancer. The Europe's Beating Cancer Plan has been co-designed together with the Mission on Cancer, and now we have the Knowledge Centre on Cancer, which was launched last June to make the scientific and technical connections between all these European Commission initiatives. This is really important. Political goes so far, science goes so far, bring it together and get it out there. We all know it. We know really now in Europe what to do. We even know how to do it. The problem is we're not doing it. And this is where we need to go. There are many other initiatives in the Europe's Beating Cancer Plan and the mission that will complement that. For example, the European Cancer Imaging Initiative, the objective eliminate cancers, okay, for HPV by 2025. That's not for colorectal, but that's also a very important one. The review of the council recommendation is ongoing. The group of chief scientific advisors will soon be reaching their opinion. We predict, not carved in stone, but lung and prostate cancers will probably be added, but this is prediction. It is not absolute evidence. We only rely on the evidence. There's enough fake news out there and disinformation, but that is coming soon. So basically, we also have the European Cancer Digital Centre. So many initiatives. Europe's Beating Cancer Plan, 4 billion. This is for the EU member states and Greater Europe in many cases. So let's all get on board with that. From the perspective of the Joint Research Centre, I want to bring you some recent news. I heard Mark and a few people talking about data. Data is power, data does things, and it's true. And also the double-edged sword, as you mentioned, Tamsin, about the data. Well, we have this European Cancer Information System, which Tit also referred to, thank you, Tit. And basically this is going to expand and grow in the coming years because of this momentum on cancer. We will be adding, and imagine this now for colorectal cancer, treatment and staging variables. They're not in there. We will be improving the timeliness of the data. We're also, we've added childhood cancers, not so prevalent, relevant for colorectal cancer, but not excluded on the 6th of December last year. We will also be geopositioning the data to link up to cancer determinants. Again, maybe not so, well, it is also linkable. Socioeconomic indicators, as you mentioned, behavioral indicators, also, even cultural differences. And that brings me to another part. Just before I leave the European Cancer Information System, we will also be looking to see how to integrate the monitoring of screening programs in the European Cancer Information System. Again, we need to monitor and show what works and what doesn't work at the EU level. This will facilitate that. So when you're monitoring the impact of a screening program, you can quickly show, and you don't need to wait 5 years. You can very quickly show if it is working or not. This can give momentum and speed to go in the direction we need to go in. On the 2nd of February, our president, Ursula von der Leyen, she launched our new European Cancer Inequalities Registry. Inequalities came through the discussion many times today. This will be also very powerful for leveraging the change. The Inequalities Registry is not about naming and shaming. It is about showing the unacceptable gaps that exist. Some of them were mentioned today, one country to the next, etc., etc. It's already online. I can put the links in the chat. And already we have indicators on sex, indicators of inequalities between countries, on education, on income, and also on demographics. That's just the beginning. That's going to grow and expand, linking to screening programs, linking to data, etc., etc. In the European Cancer Information System, incidence of cancers, colorectal cancer lies 3 and 4 in the total incidence throughout the European Union. Completely unacceptable, considering what prevention can achieve. And there, the emphasis on prevention, diet, physical activity, etc., will play an important role. There's a lot of emphasis on prevention. This is very relevant to colorectal cancer. You mentioned stage 1, 90% survival. Stage 4, was it 15-20% survival? Incredible. And also in that area, real opportunity. So the GRC is now started, and I know Ciaran knows that quite a few know that, in developing the European guidelines and quality assurance scheme for colorectal cancer in Europe. Now, this is about providing minimum standards, making sure patients don't fall between the cracks of the healthcare pathway, making sure screening is efficient, etc., etc. Just for your information, we're in touch with the International Federation of Clinical Chemistry and seeing how to improve the screening aspect. Fecal ocular blood test, FIT, all that area. It's a very basic, non-invasive testing method, plus 50, from 50 years on, this should be more available. We should have more testing, maybe self-testing, etc., etc. Hemoglobin in a stool sample is very easy to detect. So there we're looking with them to see how we could make tests more available to households, get them in the pharmacy, or maybe even provide them, as some countries do, to really start catching these cancers early. As well as that, we're now providing the, we're finalizing the executive committee for the European colorectal cancer work. We've learned a lot from the breast cancer. We will not have two groups, one group on guidelines and one group on quality assurance. We'll have an integrated group together, dissolving, forming as we need to proceed. Our deadline to provide those guidelines is 2025, together with the cervical cancer guidelines, and that we will do in collaboration with the International Association, the IR, International Association for Cancer Research in Lyon. Basically, there's some news, some comments about the policies. Yeah, completely agree. Data intelligence registries, well, the registries aspect is going to grow. We're also looking into helping the registries more through some of this funding, because that is the key. You mentioned patient centricity. Well, we as the GRC, we're independent, even within the Commission, of political entities. We're not DG Health, we're not DG Environment, we're not DG Transport, Energy, you name it. We provide independent evidence to the policy-making process. So I think that is a great thing to put us in a way in the center and make the patient or the citizen first. That centricity part is really important. And indeed, we need more action. So follow the movements within the Commission, please, because the Commission is doing all this for the member states, for Europe, and together we can really, I'm confident, move from words, as mentioned by many speakers, to impact, and then show that, measure that, show that, and that will give us the momentum. We just need to take off. It's like the airplane hasn't really taken off yet, and it is time. Tamsin, back to you. I'll be happy to try and take any questions if there are any, and thank you again for this opportunity.
Great, thank you very much, Ciaran. You've given us an enormous amount of information. I was scribbling notes as you were speaking, and I'm sure when we record this and share it with others, they'll have a chance to digest a lot of this information. I'm just struck by something that you mentioned, which is when we talked about screening, about the different types of cancer that can be screened from. Colorectal cancer with the FEAT test is probably the one of the few that is very patient and consumer friendly, in the sense that it's not one that requires a lot of specialist equipment, have to go to a hospital, have an appointment. It really is one that can be done in the home. And that's why all these programs that have, you can pick it up for free from a pharmacist, or it gets sent in the post. If there was going to be a cancer screening program where we've got the best chance of actually getting high levels of screening, my guess is it would be in this cancer, Ciaran. You mentioned learning from some of the challenges learned from the breast cancer process in the past about not having separate guidelines and screening. What do you think should be the learning about screening for colorectal cancer? Because am I right in saying this is the screening that is the most accessible? It is the one that is most likely to be done by patients, because it's the one that involves the least amount of institutions. So this is the one we should be able to get right.
Well, absolutely, Tamsin. I mean, there's golden opportunity here when it comes to screening and catching colorectal cancer early. And we know the statistics. If you catch it early, it is a completely different story, and a much happier story. So basically we know that thousands of kits already exist, even within the Commission for the screening programs. I see every 2 or 3 years there's a different kit. So there's a lot of, let's say maybe a little bit of harmonization approach, looking at the efficacy, the effectiveness, the false negatives, false positives of these test methods, coming up, perhaps the Commission now will hopefully do that, coming up with recommended kits, and then availability and self-testing. I mean, doing this once a year, sorry, but I don't think that is acceptable when it is non-invasive and easy, and it's fast, etc., etc. So we don't have any news there yet, but the work will be kicking off now this year. The experts are being set up, etc., etc. But it's very, very clear that is an opportune area, and there's no radiation dose, etc. So it's a very simple thing, and also then the preventative measures. I mean, whole meal, fruit and vegetables every day. Drink plenty of water, exercise, physical activity. All this information exists. It's evidence-based. We need to start also going in that direction. But yeah, we're looking forward to it. For us, that cancer should not be 3/4 in the European, let's say, league table. It should be way, way, way down. So that's what we plan to do in the coming years. And if we all work together, I'm sure we can achieve that. Back to you, Tamsin.
Yeah, I'm wondering if, again, in the last 2 years, one of the byproducts of the pandemic is we're all suddenly incredibly comfortable with, picking up a kit and sticking a stick up our nose, putting it into a little test tube, twisting it. We've actually become, I do that with my 7 and 9-year-old kids. Once a week we do the little test. Suddenly people are much more comfortable with the idea of doing a test at home and kits being available. I'm wondering if there is another way we can ride that wave of helping people to understand, here's another low cost, very simple kit, something you can do at home. I think there's a potential interesting crossover that we could make there.
Well, I fully agree. I think the key to tackling health and non-communicable diseases in general is citizens' empowerment and engagement. Let's take maybe more responsibility for our own health. So I don't think anybody will have an issue. Maybe initially it's not easy to perform such a test, whether it's PCR, whether it's FIT, whatever it is. But once you develop a routine, it's just a basic thing. And I think maybe it's a positive outcome of the COVID-19 pandemic that maybe we as citizens are more open to that. And self-testing will also reduce costs. You won't have to make hospital appointments, etc. Bringing samples, ideally, and I'm not. This is not an evidence-based statement, but I know from the old days of chemistry that detecting the presence of hemoglobin, blood, basically in any sample is quite a straightforward, simple test. So it should be something like a pregnancy test or something like that, where you perform the test and maybe there may be a little bit of blood, then you immediately go for your colonoscopy, sigmoidoscopy, whatever. I think a lot of people, as mentioned in the chat, are not aware of that. They think, oh yeah, colorectal cancer screening, that's very, very, no, the colonoscopy, etc., and kind of, fret away from it and maybe postpone it and whatnot. Very, very, this is a sort of a change we talk about. But the FIT part, I think, is an opportune area that we need to look into. Back to you.
Thank you. If I could invite Tit and Ciaran to look at some of the questions, because we've had in the Q&A, we've had a couple of questions. And the first one I want to pick up on is from Stephen Rowley, who says, look, early onset, that's under 50-year-olds, is recognized to be on the increase. And it's also recognized that these early onset patients are often diagnosed at a very late state because nobody's expecting it in that age group. And part of it is we need to get the GPs aware and trigger it. So first of all, would we get more early detection if we reduce screening age? Is there a cost benefit analysis here? Or should we, is it about making sure that GPs ask the right questions, or is it population awareness? How do we tackle that group? Tit, would you like to speak on that?
Yes, of course. Well, the first rule for epidemiologists is that you need trials to prove that. There is always anecdotal evidence. Why is that necessary? Sometimes anecdotal or partial evidence might be very compelling. On the other hand, one thing that we do stress, although not too heavily, just not to scare anyone off, is that, of course, there are harms related to screening programs. There are going to be false positives. We are aware of that with almost every method. And we need to be sure to make sure that not too many people suffer consequences on their health because they are identified as such. Going into younger age groups, we have some experience from the past. There has been extensive research on moving the margin for breast cancer younger, let's say at least to 45. There is still uncertainty there. But there are two other interventions that we need to keep in mind. I think you hinted on one of them already, Tamsin. It's a general awareness also of GPs of somebody even younger developing a disease that pertains to an older age group. And the other one is, of course, a stratified approach. Identifying the high-risk people. This means that we have to be more careful with the family history as well. For some cancers, and colorectal definitely is one of them, and proceed with a research. I'm not trying to discount that, not at all, to the research to see what would be the benefit of lowering the age margin. Definitely so.
Thank you. We've also had a question in from Maria, and I think, Ciaran, this is probably addressed to you. She wants to know, would treatment be covered by the upcoming guideline and quality schemes? Because obviously the logical point of getting screening is that the people who then need treatment have access to it, and what they get is of good quality. So is there a connection being made? Where are you linking them up? You've spoken about the knowledge, the Cancer Knowledge Centre. How much of this is it all going to be properly connected together?
Yeah, thank you for the question. Very good question. Yes, the Commission and the JRC, what it does is it develops new guidelines, evidence-based guidelines for screening and diagnosis. But then it also covers the complete healthcare pathway by systematically screening evidence-based guidelines, internationally accepted, validated for implementation in the European Union, and provides them. Furthermore, I think this is a very important point I'd like to add at this stage, is that the quality assurance scheme is a very particular aspect for the new guidelines. The quality assurance scheme is designed, it converts those, let's say, guideline recommendations into quality criteria, and then it looks to do with feasibility studies and piloting, etc., to facilitate implementation in the member states. So again, this is the vehicle for implementation. So having guidelines on a shelf, as beautiful and as evidence-based as they may be, doesn't do it. You need to bring them and have them implemented on the ground. Another aspect is that for the new guidelines, they're being updated in real time. The breast cancer guidelines were launched last June, and they've been updated already 3 times. This is the 3rd iteration. So European guidelines will no longer be out of date. They will be updated as new evidence becomes available, and it goes through this very rigorous process. So yes, the whole healthcare pathway will be covered, not exclusively with European developed guidelines, but guidelines covering the pathway and the quality assurance scheme. That's the key part. Thank you.
Thank you. And I think the second part of Maria's question is answered in what you've just said, because you said, how can stakeholders contribute and feed into it? And you've mentioned that there is an expert group that update the guidelines. It's just to loop in for the patient community, many of whom are engaged today. Is there any opportunity for them to feed into that? Is there any open connections? I can see you've got a mechanism, all the experts doing it, but where are the intervention points where patients could bring in their input?
Another great question. What can I say? Yeah, for the expert groups, we have patient advocates and we have patients in it. So we cover the whole spectrum. And on the website, we're always open for new evidence. Some entities are continuously providing evidence. Then we put it through this. It's a process. It's a very sound, internationally approved process, grade pro, evidence decision framework. I won't go into the details, but it's very thorough. And then it goes through this system for potential updating, but suiting all the member states. So some evidence comes through, but it could maybe only be more suited to the wealthier member states, say, but not to the other one, or vice versa. So basically, it's about that process. So yeah, always open for new evidence as it becomes available, and if it's extrapolatable to a European setting. And it's amazing when you sit together with EU countries at any meeting, the willingness to share and to share best practices, to share knowledge and all that, it's there. So I mean, anybody, and especially the experts and all of you out there, I see 75 people online, any new evidence, any know-how, we should share it together. So we're completely open for that, of course. Now, complete transparency, this is for Europe, and it would be wrong to actually close the door and create a silo. No, we're not into that. Thank you.
Thank you. Tit, let me invite you to pick up on it. We've got a question from Stephen about, is there room, we talked about a European level approach to screening, is there scope for a European campaign on prevention? And again, he's highlighted the biggest risk factors around age, smoking, BMI, alcohol, lack of exercise. And I'm wondering, the last 2 years has seen an enormous change in lifestyles. And there's some evidence coming through that while some people use the time to kickstart a fitness regime, for many people, particularly living in poor housing without access to green spaces, the last 2 years has been an increase in drinking, alcohol consumption. We've seen an increase in unhealthy foods and BMI as people have not been able to move around or have as much physical activity. So there is going to be a bump in potential cancer risk as a result of the lifestyle changes. So first of all, how do we address this, and how do we help people find a way back towards a healthier lifestyle when there's a lot of stress and we're about to experience enormous economic impact? And when we get economic impact, we know you've got an increase in stress, and stress triggers some of the unhealthy lifestyles. So this is a big public health challenge. And Tit, how are the public health community stepping up?
Yes, I think that we have several opportunities. One thing is definitely these last 2 years have contributed to a great deal in a negative impact. We've heard a lot today about delayed diagnosis, about poor access to screening programs, and you are now raising one of the central points, which is key to the future. And I think that we need to link with two other issues. Other colleagues from the NCD community, from the non-communicable disease community, were quite jealous lately because of the attention that cancer got. And I see now that the European Commission has also prepared a document that actually tries to a little bit appease these differences. When speaking of prevention, of course, diabetes community has already warned also about the obesity epidemic, which got worse, and lack of physical activity. And I think that we need to link up with them because we have a common goal. We have prevention through the same means. The other opportunity, and I think, again, you hinted nicely, Tams, in there on the green spaces. I'm lucky to live in such a part of the city where I have immediate access to green areas, but not everybody is that lucky. And in these years, and with the restrictions, people were even less comfortable of, going somewhere and moving around and so on. We need to think about, now we are talking about ecological challenges. We are trying to avoid using cars and reducing the energy consumption for our movement. We should take this opportunity in a positive sense, not as something imposed or directed on people, but as something that is actually an opportunity for all of us to facilitate people's contact with nature, movement, and so on. I will react to something else, Tamsin, if you allow me. There was a big discussion on two issues in the chat, very lively. I'm happy to see that. One is about colonoscopy. I have to say, we are convinced here in this room now. We are all convinced about the methods, but not everybody is alike. So there are people who fear. Today we heard from Mark that people feared COVID more than they did cancer. There are people who fear colonoscopy more than they fear cancer. So they don't even want to make the first step when it's not colonoscopy, it's FIT test. So we have to be aware of that, and we have to facilitate their understanding that this is not the worst test or the worst examination they are going to undergo. Another issue, culturally, some environments might be more inclined to take one or the other way. So there is no automatic prescription. I liked what previous speakers stressed, that FIT tests are simple, they can be promoted, they are cheap in the end, not to expose the public to enormous quantity of colonoscopies and so on. And I think that we need to keep all that in mind. And so this is just some of the reflections. Thank you, Tamsin, for the patience.
Thank you. Ciaran, I know you want to come back in. If I could invite you to be very brief, because I need to then close to the final session. But Ciaran, final message for us.
I'll be as brief as I can, Tamsin. No, I want to fully agree with what Tit has said. And when it comes to prevention and the comment, there's a lot of emphasis on prevention in the Europe's Beating Cancer Plan and on the mission. When it comes to, I heard about green environments and all that, we have a project now, Helios, where it is proven that exposure to green environments improves your mental and physical health. Also in the Commission, we're trying to join the dots. So you have the Green Deal, you have the digital agenda, you have the pharmaceutical strategy, you have all these entities going out. Now we're trying to work together to bring it all together, because if we're going to really tackle health, we have to do it holistically, never in isolation. We've been doing it in isolation, it doesn't work. It has to connect to all things, from behavioral, walking instead of taking the lift, your food consumption, sustainable food systems, etc., etc. Front of pack labeling, alcohol consumption. You heard about the alcohol increase due to COVID-19. Smoking, we all know it. So again, this holistic approach is coming, and it is challenging to join the dots, but the Commission is working to do that, and I think that's the way to go. To end that session, thank you so much again. Fantastic session, and yeah, we look forward to working together with you. Back to you.
Thank you very much, Tit and Ciaran, for sharing some perspectives and answering these questions. And as you say, the chat was really lively. Lots of conversations about people saying, we just need to make this happen. It takes a long time for guidelines to be changed. Let's move to action. So clearly there's a lot of interest.